Thank you so much for joining our Facebook, our Zoom Live, our webinar, Colic Uncovered. We had hoped that we would be able to do this at the clinic, and we've been planning to do this for about the last year, but unfortunately, due to the pandemic, we haven't been able to. So we do still plan to have a clinic-based talk when we're able to, and that will give you a chance to be able to have a look around our facilities, including our surgical facilities, which I think you'll find quite interesting. So look out on our Facebook site, and we'll also do an email out as well when we're able to do that. This evening, we've got 3 speakers for you, 3 of our vets, Claudia, Manon, and Nuno. And the evening will be split into 3 parts. So Manon will start off by talking us through the signs of colic. She'll talk to you about when to call the vet and what to do whilst you're waiting for the vet. Then we'll move on to Claudia Gilders, who will talk to you about medical colics and the different types of medical colics. And then we'll move on to Nuno Siqueira, and he'll talk to us all about surgical colics and the whole surgical process.
Jack, I'm afraid you blocked my camera, so I don't think people can see me.
Have you gone?
I think you blocked, as a host, you put my camera off.
Hang on.
Sorry to interrupt.
No, that's fine. Manon, I'm making you the host.
Okay.
Because my screen has cut half off, so that might help us. If you could just if you could change the settings for Nuno there.
Perfect.
Yes. All right.
Fantastic.
Yeah, he's back.
Okay, so let's start the evening with an introduction from our speakers, if that's okay. So over to you first, Manon. If you could introduce yourself.
Okay, so I'm Manon. I joined Cliff in September, so I'm quite new in Cliff. Before I worked in Belgium in a hospital called Equitom. It's a referral hospital there. I was doing a bit of everything, orthopedics, a bit of diagnostic imaging, internal medicine, and I was responsible for general anesthesia, emergency admission, and inpatient care, so including intensive care, so colics, medical and surgical. And here you're going to find me most of the time on the road. I also really enjoy the clinic, and my main interests are orthopedic and surgery. And I'm currently working on a certificate in surgery.
Thank you, Manon. Claudia, do you want to introduce yourself?
Yep. Hi, I'm Claudia. If you don't know me already, I did my internship up in London doing similar things that Manon did, and then I moved back home to Sussex to join Cliff, and I've been here for almost 3 years now. I am either out on the road or in the clinic like Manon, and I'm just about to finish my certificate in internal medicine because that's where my main interest lies.
Brilliant, thanks. Nuno?
Hello, good night. Thank you very much, everyone, for joining us. So I have a bit of a different background than Manon and Claudia. I did a little bit of wildlife work, so I'm also quite interested, besides horses, in nature and wildlife. So I did that for a few years. Then I went to do exclusively horses now for some years as well. And I was at the same place as Manon in Belgium at Equitom, also a referral center. So we did quite a lot of colics and a lot of colic surgeries and a lot of intensive care, and also I have a special interest in surgery and orthopedics, and I've joined Cliff 8 months ago, so I hope to see you all around.
Thank you so much. Manon, do you want to start us off with the presentation?
Yeah, can you just want to check if you can see the presentation? Can you see it?
Claudia, Nuno, can you see it?
Yeah, I can see it, yes, sorry.
If they can see
and
it,
the audience, can you see?
Yeah, they've just said yes, yeah.
All right, perfect. So should we make a start?
Let's do it.
All right, so the aim of the talk is to present you what is a colic, what's the different step to work up a colic, and then the different types of colic and the treatment available. So basically it's just so you can understand a bit better this condition and be more prepared if at some point you face like this emergency. So we're going to start with Is it working? Here we go. So we're going to start with an overview about colic. So how to recognize the colic, how to recognize the signs, and what to do. And we're going to go through the workup of the veterinary workup. And then we're going to go through the different types of colic. So first the medical colics and then surgical colics. And we will finish with Nuno talking about surgery. All right. So Jack, is it okay? Yeah. All right. So first, what is a colic? So colic is a general term used to describe abdominal pain. It's not a disease in itself, but it describes several conditions leading to gastrointestinal pain, so symptoms, and it's called colic symptoms. The majority is gastrointestinal, but you can have something else, but most of the time it's gastrointestinal. And the severity can vary quite a lot. We can have really mild signs, just inappetence or horse a bit depressed, but we can also have very severe signs, horses rolling and really really violent. So it's 1/3 of the emergency calls we have, so it's quite a lot, and it's the first medical cause of death. So that's why it's really important to act quickly and important to be aware of what is a colic. So why horses are prone to colic more than other animals? We never heard about colic for dog, for example. It's because most of the time it's mainly because of the gastrointestinal tract anatomy. It's quite particular for the horse. So as you can see on this picture, so this is a gastrointestinal tract of Welsh pony section A. So it's quite a small pony, and you can see it's quite a big intestinal tract. So we have here, I hope you can see my mouth. So we have here the esophagus, here this is the stomach, here we have all the small intestine here, so it's 21-25 meters, so quite long. Here we have the cecum, and then we go for the large colon here, and then small colon and the rectum. So the large intestine is around 5-7 meters, so it's really long intestine, and it's attached with to the abdomen with loose ligaments, so it's really easy to move and also really easy to twist. Also horses, they cannot vomit, so if you have an obstruction, for example here, you can have all the contents and the fluids coming back to the stomach, and as they cannot vomit, the stomach is just going to distend itself, and this is really can be really painful, and that's one of the causes why horses can be very painful on a colic. And also in nature, the horses are supposed to graze the major part of the time and ingest small quantities of food in a long period of time. So now we're giving, most of the time we're giving like 1, 2, or 3 feeding per day. So it's a large quantity of food in a short period of time, and the horse is not adapt, like the digestive system is not adapt to that, so that's why they're more prone to colics. So what are the clinical signs of colic? So most of the time they're pawing the ground or they're flank watching, they look a bit uncomfortable. You can see in this image the horse is just watching his flank, and you see that it's not comfortable. It can also be agitated or depressed, depends, can be both. Sometimes, or most of the time, they don't want to eat. They didn't pass any droppings, or the droppings, they pass reduced amount of droppings. But they can also lie down or roll. So as you can see in this video here, so they can roll and feel quite uncomfortable. You can see they have quite a lot of shavings normally, and the stable is normally not really tidy. So that's something who can help you to know if it's if you had colic before and now it's not showing maybe. They can also adopt this stretching position, so it looks like you want to urinate, but they don't. So that's also a sign of colic. It's less common, but can be. And they can also kick their belly. So there is the British Horse Society, they did this campaign about colics called REACT. So REACT for the different signs of colic. So restless, eating less, abdominal pain, clinical change, and tired or lethargic. I think it's quite easy to remember with this React, and I really invite you to go on this website if you want more information, because they did quite a lot of leaflets about about colics and different things. So it's quite useful if you want to go for more information. So now, what are the risk factors? So there is a lot of risk factors, and we can control those risks, try to decrease the incidence of colics. But even if we do everything right, sometimes they still have colics. So it's not, sometimes it's just unfortunate they have colics. But of course, if we manage those risks and just decrease the incidence, there's going to be less chance to have colic. So first, we can start with the feeding. I think it's one of the most important. It's really important to have a good quality of hay or grass, and let the horse eat small quantities for a long period of time. So of course, if they are outside in the field, it's much easier. Also very important to have source of water, unlimited, and also the water need to be clean, clear, and also quite temperate. If it's really cold or if it's frozen, for example, in winter, we have quite a lot of colics impaction. It can lead to impaction. So the housing, it's a bit the same as the feeding. So a horse in the field is going to be able to walk, it's going to be able to eat small quantities during 8, 10, 12 hours. So it's going to be less likely to have a colic. While the horse inside in the box, they're going to eat maybe 3 times a day, but they're going to eat quickly because they don't have anything else to do. So they're just going to eat really quickly and just in one time. So that's why sometimes the hay nets are really good to just let them pick the hay for a longer period of time. Internal parasitism, it's also really important, and I think it's really easy to control. It's just very important to have a good warming program. Parasite, they can cause diarrhea or obstruction. We're going to show you after a video and a case of obstruction with Parascaris. But I think it's quite easy to control. We just need to have a good warming program, and we can reduce this kind of colics just doing that. Also, weather changes and season changes. So normally we see more colics when the season changes. So in spring, for example, or in autumn when the season change, and also when the weather changes. So sometimes when we have a storm, we have more colics. So that's also something to consider, even if we don't really, we cannot control the weather. When to call the vet. So we just have to keep in mind it's an emergency. Normally, wait and see doesn't really work here. So I would not really advise against to just wait and see if he's doing better. Normally they don't. And time is of essence. So the earlier you call us, the better it is for the horse, because we're going to be here early, and sometimes time is really important. So if you have any doubt, just give us a call. If you have any doubt if the horse is showing a colic sign or not, just give us a call, and we will be able to answer your questions and determine if we have to come or not. If you have a doubt during the night at like 5 or 6, it's better to make sure it is fine and not leave it the whole night, because sometimes we arrive the morning and it's really bad. So it's better to be too soon than too late. So how to be prepared with colic? So as I said earlier, time is of the essence. So the more prepared you are, the faster your horse will be treated, because the faster we're gonna call the vet, come, take the decision, etc. So first of all, you really need to have your vet contact or emergency service contact. So this is the number of Cliff. You can find it online. It's really easy to have it on your phone or even in your yard, so you have access quite easily. Also important, if the horse is insured, is it covered for colics and for how much? So that's really important to know before, because of course colics involve a cost. So if we know that the insurance cover you, maybe we're going to do things that we will not if it's not covered. So it's really important to know before. So yeah, we don't have to lose time calling the insurance, and same if it's on Sunday at 10, the insurance will not answer you. So yeah, if you don't know, just read your policy or give a call to your insurance. Also the transport, so do you have a transport available, or do you have the number of transporter just in case we need to take the horse to the clinic, for example. It's useful to have this. And what option are you considering? So I hope after this webinar you will know a bit more about the different treatment option, and maybe you can think about what you could or you would want for your horse. Of course, you cannot take the decision now, but it's just if you already know and thought about it, the day you will have to take the decision, you might be a bit more comfortable to take it, and also it's going to be less stressful. So yeah, it's really difficult decision sometimes to take. So it's and in a short period of time. So it's always better if you're prepared for it. And also important, if you're not contactable, to give instructions. So for example, at your yard manager or to a friend or someone. So if at some point you're not contactable, we know what we can do and what we cannot. So that's also something you can do. So what to do while you're waiting for the vet? So you call the vet, you're waiting for it. Just so put your horse in a safe area. So it can be a box with deep bedding, or it can be the same school, just you attach your horse with the lunge line and you stay away. You can walk the horse if he's fine. If he's not too violent, you can walk him. You can also monitor feces and gas production, and you can prepare if it's appropriate, if the horse is really showing severe signs, or if it's appropriate, you can already start to organize the transport. Remove the food, don't give food or sometimes water, but the vet will tell you. And also really important, don't interact if the horse is violent. So if your horse is rolling and really violent, don't try to interact, just stay and let him roll. It's not going to change anything by not letting him roll. So just let him roll and just stay safe because they can be really violent, very painful, and they can hurt you even if they don't mean to, but they can really hurt. So just stay safe. Don't lunge your horse before the vet examination. There is, for some colics, we can lunge them and it's part of the treatment. But for others, it's really contraindicated. So wait for the vet before trotting or even cantering your horse. Just wait for the vet before. And don't give any medicine without the vet approval. For example, if you have phenidine or bute, it's painkiller. So if you give it before, it can mask or change the clinic. So just wait for the vet to tell you yes or no. And if you did, just tell to the vet so we can take in consideration. So what's the different step for colic consultation? So first, we're going to go for clinical history. So we're going to ask you since when the horse is showing colic sign, if he had colic before, when was the last time he ate, did he pass droppings, are the teeth up to date, is he warmed, etc. So it's just to give us an overview about the case and the history of the horse. And then we're going to do a clinical examination. So with this, we're going to evaluate the degree of pain of the horse and also how he is systemically. So if he's dehydrated or if he's in shock or if he's systemically still fine. It's just going to help us to know a bit more about, to start basically, and to know a bit more about the colic. Then we will go for a rectal examination. So we can, with the rectal, we can palpate quite a lot, but it's still the caudal part of the abdomen. We cannot palpate everything because the horse is really big. So it's just the caudal part of the abdomen, but we can palpate the spleen, we can palpate a part of the kidney, also the colon and the cecum. We can also palpate small intestine, but when you palpate it normally, it's not really good. So sometimes we have the diagnostic with the rectal examination. Sometimes we don't have the diagnostic, but we have some clues about the types of colic. About nasogastric intubation, so it's passing a tube from the nose to the stomach, and we're going to check if we have reflux. So as I said earlier, the reflux is accumulation of fluid in the stomach, and it will the stomach will be distended, and you can have a stomach rupture at some point in very severe cases. So the fact that passing the tube will help us to remove this fluid. And also, if there is no reflux, we can also pass some treatment. So here, for example, you see Claudia passing some water with electrolytes. So it's a treatment. So those 4 steps we normally do in the field. It's not we not necessarily do all the steps. It will depend of the case. Sometimes we don't do nasogastric intubation, or it will depend of the case. And yeah, the vet will know what step he wants to do and will tell you. We can also do more. So we can do also blood analysis. So mainly it's going to allow us to evaluate the hydration state of the horse, and also the degree of gastrointestinal compromise. And we can also do an abdominal ultrasound. So we're gonna visualize different parts of the gastrointestinal system. We can see the kidney, we can see the colon, the spleen, the stomach. We can also see the liver and the small intestine. So it's just gonna give us a clue about what's going on, and also help us to know if it's a medical colic or surgical colic. We can also see, so I'm just gonna show you this video. So as you can see here, those loops, those black circles are distended small intestine, and you see that they're not motile. And we have here the colon here. So yeah, we can have quite a lot of information with the abdominal ultrasound, and we can also see if we have some fluids, and it's going to help us for the next test, which is the abdominocentesis. So it's also called belly tap or peritoneal tap. And we're gonna sample the fluids of the abdomen. We're gonna sample it with a needle or cannula, and we're gonna analyze this fluid, and it's gonna help us to determine the severity of the colic and also the prognosis. So all of those steps, we don't doing it all the time, all of it, but yeah, it will depend of the case, and the vet will tell you which one we have to do. And sometimes even with all of these tests, we're not 100% sure of what is it, but at least it's helping us to know if it's if we go to a medical treatment or a surgical treatment. So that's for my part. So before Claudia is going to do her part on types of colics, if you have any question, we can wait 5 minutes and answer the question. Thank you.
Thank you, Manon. Marvelous. That was very interesting. We should have mentioned at the beginning, and my apologies, but there should be a Q&A tab at the bottom of your screen to allow you to ask any questions. We might just take a couple now, and then perhaps save the majority of them until the end of the talk. So I have a couple of questions that were emailed in previously, Manon. Can I ask them to you?
Yes.
How quickly would you expect a horse to respond to pain relief at the initial call out?
So it depends. So if it's pain relief, for example, Phenadine, I would expect maybe 15-30 minutes. And it can last, so the maximum effect will be 6-8 hours, and then we can, yeah, the effects will decrease. If we give Buscopan, so it's antispasmodic, the effect is immediate, like, yes, so maybe a minute or something. And if we give sedation, for example, Torbjörn is a bit analgesic. If it's in the vein, it's going to be quite quick also.
So if the horse doesn't respond to any of those in sort of like the first 15 to 30 minutes, would that be then the decision to take the horse into the clinic?
Yeah, it will depend. It depends also of a lot of things. It can depend of the clinic also. But yeah, the response to analgesia is something we really how do you say, taking consideration to know if we go to the clinic or not. But normally, if they don't respond to analgesia, we also have the clinic is not like the best clinic case. So normally we can send them to the clinic quite soon.
Okay, thank you.
Yeah.
There's a question here from Ruth. Once a horse has had colic and recovers from it, is it more likely to have colic again?
So I'm going to respond like way. So if it's not true, well, if you have surgery, you have some risk sometimes to have adhesion, for example, and the colic can reoccur. On nephrosplenic entrapment, also you have some horses, they're more they have maybe the ligament a bit more long, and yeah, they're more prone for entrapment, so maybe they can do it again. But I'm not sure there is any link about having one colic and having recurrent colic. I don't know what you think, guys. Claudia, Nuno.
I would say sometimes it's completely situational. So, for example, like Manon said, if the water's frozen and they haven't had a drink and that's led to them having an impaction, that's not necessarily them being predisposed to a type of colic. So if we change those management things, hopefully we would be less likely to have them. Some horses will have repeat bouts of colic. So some of them we don't necessarily get down to the initial cause the first or the second time, because they might be some things that need more of a workup. So some horses can be more disposed to colic. I think it kind of depends on their management, their environment, their own gut flora. So there are some things we just can't change, and some horses will be more predisposed. I don't know what you think, Nuno, but
exactly, it really depends on what's causing the colic in first place and how severe it is. But I agree with both of you. So I think if it is a surgery, there's sometimes complications, but most of the time is not. If it is medical colics, if there are predisposal factors, obviously, yeah, they can play a role there.
Fantastic. One more question before we move on to Claudia's part. I think this is a really nice question from Lorraine. And one that will be relevant to a lot of us. Claudia, I'm going to direct this to you.
Yeah.
Is riding or exercising too soon after feeding a big risk factor for colic? How would you approach this regarding horses who suffer with ulcers and so need to have their stomach lined before riding?
Yeah, so I think we used to, or I think some people think that feeding before riding is not a good thing, but actually the more current thinking is that we like those horses' stomachs to be lined. And so we usually recommend that horses have kind of the equivalent of a quarter of a hay net, or at least a scoop of more fibrous feeds, in particular before they're ridden. And that just provides a really nice fiber mat in your horse's stomach, and stops the acid splashing at those sensitive parts of the horse's stomach and stops those ulcers forming. So I wouldn't suggest that feeding before riding is too much of a risk factor in terms of colic. As long as we're not feeding the really high carb things, it's more of a fiber that we want them to eat at kind of at least half an hour before you ride.
Brilliant. Thanks, Claudia. Shall we save the rest of the questions until a bit later on, and maybe we could move on to you, Claudia, to talk to us about the different types of medical colic?
Sure.
Thank you.
Cool. So we're going to talk about the types of colic we can get. We can typically broadly categorize colic into two types, so medical or surgical colic, depending on what we need to do to treat them. It's not a completely hard and fast rule. A lot of the time they will be fixed medically, but some of those that we would typically treat with just medical intervention, it doesn't always work, and they do end up in surgery. So these are some examples of medical and surgical colic. It's not the only types of colic. There are many causes. These are just some of the ones we're going to go into a little bit more detail and explain a bit more about. So firstly, we're going to talk about spasmodic colics. And so spasmodic, or kind of colics of not complete diagnosis, make up about 60 to 70% of the colics that we see. The term spasmodic colic actually describes the symptoms rather than the cause, as there's very little scientific evidence as to what's causing those gut spasms. But what happens is the horse's gut spasms, and they get these intermittent, sharp, painful sensations in their gut. So horses can sometimes have mild signs, but they can be a little bit more painful. But what's typical of a spasmodic colic is that they're quite self-limiting. So sometimes the colic will have completely resolved by the time we get to them, or they might take a little bit longer. But we usually treat these with an antispasmodic. So that's a drug called Buscopan, and that relaxes the gut's muscles and stops those painful contractions. We'll also give some pain relief, and we might ask you to lunge your horse around. Next one, Manon. Thank you. So moving on to the next one, tympanic colic. So that is also known as a gas colic. And this is when gas will accumulate in your horse's intestine, and that causes it to stretch, which can be quite painful. So this can massively vary in colic signs. They can be very mild, but they can also be very, very painful with this. Based on the physical exam, we can be quite suspicious that this is going on. Sometimes when we look at your horse, they are very bloated. And also when we listen to the horse's gut sounds, they can be very, very loud. So sometimes you can actually hear them without a stethoscope, and they can sound quite high-pitched and pingy where the gas is trapped. We can also, again, diagnose this on a rectal exam because the guts are quite gas and distended. Again, we treat these similarly to spasmodic colics. So we'll give them some anti-inflammatories, some antispasmodics, and the lunging is a very important part of this treatment because it helps that gas pass and relieves those painful sensations. So moving on to impactions, these are where there's an accumulation of material in your horse's gastrointestinal system that either leads to a partial blockage or a complete blockage of those intestines. They can occur in lots of different locations, so there's many types of impactions. So they can occur in the large colon, the small colon, the cecum, the stomach, and they can occur from different materials, so you can get impactions from sand as well. So the first type of impaction we're going to talk about is large intestinal impactions, and these are the most common types of impaction that we come across. This is where there's an accumulation of dry feces that cause a blockage in your horse's large intestine. So as you can see in the picture down below, the large intestine moves down the bottom of that picture, and as you move towards the rear end of your horse's abdomen, there's something called the pelvic flexure, which is a very badly designed part of your horse's large intestine, because not only does it narrow, it does a 180-degree bend on itself. So this massively predisposes it to getting blocked. We diagnose this on a rectal exam normally. So when we will have a feel, we feel these very large doughy impactions. The signs for these are typically more on the mild side, but not always. Horses may go off their food, they may have a reduction in their droppings, or they might just be quite quiet. And that's why it's always quite a good idea to know what's normal for your horse. So if you come down and, oh, sorry, Manon, can you just go back? Thank you.
Yeah.
If you have slightly less droppings than you're normally expecting, that might highlight you slightly earlier on that something is going on, and you might just need to monitor the situation. So we treat these with some fluids normally, because we have to rehydrate that big dry mass of feces in there. So normally we will pass a stomach tube and we'll put some fluids in there, which will hopefully soften that impaction. Most impactions will clear with just 1 or 2 stomach tubes, but some of them are particularly stubborn. And we have to bring these into the clinic because they might need quite intensive treatment, so tubing them into their stomach every couple of hours, or even intravenous fluids. So like Manon said, the risk factors for these, so a lack of water, because that dehydrates your intestinal contents, changes in the diet or management. So we can sometimes see these when horses have to go on box rest for an orthopedic condition, for example. So that's when we really need to try and make sure they're drinking as much as possible, and also dental disease. So it's important that we get our horses' teeth checked regularly. So another type of impaction is a gastric impaction, and this occurs in your horse's stomach when the food kind of forms a really hard, dry ball, which can be really difficult for the horse to clear. So these again are typically quite subtle signs of colic, and they may show no signs at all. They are quite similar signs to gastric ulcers as well. So sometimes we see them when we just do a gastroscope. And when we gastroscope a horse, we will starve them for 16 hours to make sure that stomach's completely empty so we can see all the different parts of it. If we have starved your horse and it looks like these pictures down here, it's much more full than it should be. And that might make us believe that there is some form of delayed gastric emptying or an actual impaction in there. And so we treat this, we again need to rehydrate that contents and get them back out. So we'll perform something called a stomach lavage, where we fill the stomach full of water and we try and siphon that contents back out. And we can also put Coca-Cola in your horse's stomach. And that works really well to kind of break down those really hard, dry balls of gastric impaction, and then we can lavage them back out again. So sand impactions, they are not something that we typically see in England very often, but they can occur. They're much more common in areas such as America or Finland when the horses are out in sandy pasture a lot more often. And what happens here is the sand sinks in your horse's intestine and causes a bit of an impaction, and it really irritates the lining of your intestine. So these horses can show signs of colic. They can have diarrhea, or they can have kind of this chronic weight loss not quite right going on. So the way we diagnose this, one test is called the fecal sediment test. So as you can see in the picture on the right hand side, we put some feces in a glove with some water, and what would happen is if there's a very high sand content in there, that will drop to the bottom, and that might make us be a bit suspicious there's a lot of sand going on in there. But the definitive way we diagnose this would be on X-ray. So as you can see in this picture here, the sand shows up quite bright white, and this is a horse with a large amount of sand sat in its intestines. So to treat this, we need to give them some fluids into their intestine, and we also add a binding material called psyllium, and that forms this very hard, very jelly-like mass, which helps pass the sand out of the intestines and out in the feces. So moving on to displacements. So this is when a piece of your horse's intestine moves to an abnormal location. So as Manon just said earlier, your horse's intestines aren't attached in very many places, and so that can move around. And your horse's large intestine sits in kind of two horseshoe-shaped structures sat on top of each other. And so many different types of displacement can occur. The most common types, a piece of the colon on the left can flip over to the right. A piece of the right colon can flip backwards on itself, or pieces of the colon can get trapped in between different organs. So the signs can vary massively depending on where the gut is and how much it's moved to an abnormal location. We don't ever get a definitive diagnosis as to exactly what's happening, but we do get a good idea of what's occurring from a rectal exam. So we can feel that there is a piece of gut in a place where it shouldn't be, but the only way we'd know exactly what was occurring is if we took that horse to surgery. Some of these will be able to be treated medically. So with lunging and something like a jiggle around, usually the gut will move to the right place again. But some of these will require surgery to be properly untwisted. So one of these types of displacement that we see is called a nephrosplenic entrapment. And so that's when a piece of the large intestine moves and gets caught in between the spleen and the kidney. And they have a ligament that goes between the two organs, and a piece of gut can move up and just get trapped there. So we can diagnose this on a rectal exam sometimes because we can feel there is a piece of gut in between those two structures, but we can also diagnose it on an ultrasound. So on the left-hand side here, this is what should normally occur. So the spleen and the kidney should be sat next to each other on an ultrasound. But on the right here, we can see that there is a piece of colon sat next to the spleen instead. So when we see that, that's when we know that this is what's occurring. So we would treat these with some pain relief, some lunging, but we can also give a drug called phenylephrine, which causes the spleen to actually contract and shrink in size. And that means there's a much bigger space for that colon to move back into its normal place. So moving on to the more surgical causes of colic, again, any of those sometimes do require surgery to fix, but these are the ones that we're going to talk about now, typically always need surgery to treat them. These types of colic usually have quite severe and continuous pain. They might not respond to the pain relief or the sedation like a medical colic would, and some of these horses are quite systemically unwell, so they're showing signs of toxic shock. So a particular type of surgical colic is called a strangulating lesion. And so this is when the actual passive of your intestine and blood supply are cut off completely. So these typically occur in the small intestine. And the most common cause of a strangulating lesion is what we call a lipoma. And these are lumps of fat that grow in your horse's abdomen on a little stalk, which just randomly will twist around a bit of your intestine and completely cut off its blood supply. So you can see in this picture here, this fatty lump is wrapped around, and the dark red pieces of gut there are actually gut that's starting to die. They can occur from other reasons as well, so hernias, which is why if they are large, we'd always like to treat that to try and stop this occurring. Any tear in your intestinal lining, and also entrapments, which we will talk a bit about on the next slide. So the second most frequent cause of small intestinal strangulation is called an epiploic foramen entrapment. So this is another badly designed part of the horse where this is a completely normal hole in the horse's abdomen between the liver, a large blood vessel called your vena cava, and your pancreas, and a bit of the small intestine can pop into there and can't get back out and starts to die. The reason we talk about these is risk factors for these usually occurs in the larger breed wide-chested horses, but windsuckers can massively predispose themselves to this type of colic, which is why we would discourage this type of behavior from occurring. So moving on to the types of surgery that occur in the large intestine, where we call them torsions or volvulus. And so a torsion is where your intestine twists around itself, and a volvulus is when not only it twists, it kind of will flip on itself as well, so it is even more severe. And this cuts the blood supply off to your large intestine. These horses typically will present quite sick because when the blood supply is affected, you get something called a leaky gut. So you get a lot of bacteria that leaches from your gut into your horse's main system, and they get quite systemically unwell and start to go septic. So it very much depends on how much is twisted as to how severe the colic could be. It can be quite simple, so they just twist 180 degrees. They can twist a couple of times over, and all the way to 720 degrees plus. So you can see in this picture here, that's a piece of your large intestine that's twisted around itself a couple of times. You can see how large the intestine is here. So you can see how big it is compared to the hand. So usually to untwist this in surgery requires more than one person because it's very heavy. So risk factors for this, again, the larger breed horses are more predisposed to this. Post-foaling mares as well is a worry. If they start to colic after foaling, we always take that very seriously because they had a large foal taking up a large portion of their abdomen, which is now gone. And that means there's a lot more space for everything to move where it shouldn't do. So yeah, these always normally require surgery to fix. So those are just some of the main types of colic. If you have any questions, we can take them now.
Thank you, Claudia. Brilliant. Just whilst people put their questions into the Q&A tab down at the bottom, I've got a question that came in by email before this evening. Claudia, I'll aim it at you. Do you still tube horses who have impactions with oil or liquid paraffin?
I think that's definitely something that used to occur. We have moved away from that treatment now, typically. There has been some good studies out there that have showed that when you put a dry fecal ball in liquid paraffin and compared to water and electrolytes, the water is a lot more effective at rehydrating that and breaking up. The liquid paraffin is more of a lubricant and not necessarily hydrates it as well. So typically we will treat those horses with water and electrolytes now.
Thank you. In response to you mentioning in the last Q&A session about feeding horses before work, we've just had a question here from Kat, and she says, is the feeding a bit of fibre 30 minutes before riding better for all horses or just horses that suffer from ulcers?
I mean, I would recommend it for all horses because I think it's always a good idea to help prevent ulcers occurring. So we do know that exercising on an empty stomach predisposes your horse to get ulcers. So prevention is always better than cure. So I would always recommend that horses get fed before they're ridden.
And another ulcer colic related question from Julia. Is a horse with a history of ulcers more likely to get colic?
I suppose horses with ulcers can colic. So ulcers are a type of abdominal pain. So they can colic with it. Some horses with ulcers will typically colic sometimes around feeding and things like that. It doesn't necessarily predispose them to other types of colic, but things like stress, etc. can. So if your horse is stressed with its ulcers, or if it windsucks with its ulcers, then yes, it may predispose them to other types of colic.
Thank you. Here's a question. So could over rugging and thus the horse overheating lead to colic?
I suppose yes, in the fact that if your horse is overheated and sweating excessively, then they may be more likely to get dehydrated, which may predispose them to getting things like impactions and something like that.
Brilliant. Shall we move on to the next section? And Claudia, you can have a sip of wine. I think you've earned it. We move on to Nuno now, who has waited incredibly patiently as the numbers and our participants have gone up to, I think, 112 now. So thank you for all joining. If we move over to Nuno now, who's going to talk to us about the surgical colics.
Just can I check something? Do you see my mouse when I show the stuff? Yeah.
Yeah.
Okay, perfect.
Yeah.
So unfortunately, we don't have any tests that allows us to decide if a colic is surgical or not. So we really rely on the history and on the clinical signs. So we have some diagnostic tests we can do, obviously, and those will help us to make that decision and try to assist you what would be the best option for your horse. And what became really useful and something we use more and more is the ultrasound. It allows us to have a good non-invasive view of the gastrointestinal tract. And here we can see in this in the picture on the left, like Manon already also showed in her presentation, quite big distended non-motile, so not moving loops of the intestine, and this is normally related to some kind of obstruction, and this can be an indication for surgery. Then we can also sometimes diagnose intussusceptions, which are in fact adjacent portions of the intestine that go into each other, and we can see that on an ultrasound by seeing quite a clear donut kind of shape, and this is definitely a reason to go for surgery straight away. And then we have other parameters such as the peritoneal fluid, which is the same as the belly tap that we discussed previously. If it has this reddish pinkish appearance, normally it's because there's something severe going on, normally some kind of strangulation or some kind of really serious thing ongoing. So this is normally an indication to go to surgery straight away. We also measure different things like protein, white blood cells, and also lactate, which is something that indicates that something stressful is occurring in the GI, so in the gastrointestinal tract. The other thing that we check for, like we already mentioned, is the gastric reflux. So if there is reflux, normally it's because there is some kind of obstruction within the gastrointestinal tract that makes the fluid to accumulate in the stomach. So all these tests are tests we do routinely if we think they're necessary and help us to decide if surgery is needed or not. Even horses without any of these signs can be surgical, because these signs take time to develop. So if we have a horse that just had a strangulation, these signs potentially are not still there, but we will have to go to surgery anyway. Manon, could you pass for the next slide, please? So baseline, the most important thing is the response to analgesia. So if we cannot, with painkillers and with the drugs we give your horse, if we cannot make them comfortable and calm, normally these horses do request surgery, and frequently we do not have a final diagnosis when we go for surgery, because the diagnostics we have available are limited, and also sometimes we don't have them accessible. So what we do is, if pain, what we generally suggest, this has Manon?
Sorry.
Okay. What we generally suggest is, if the colic is not responsive to pain relief, this is the benchmark, and this is enough to make a decision to go for surgery. And let's do this sooner rather than later, because time is really important here. Because if we have a gut that is strangulated, for example, which will cause really painful colics that we cannot control by any means, we really need to go to surgery straight away, and this will be really important in terms of the viability. So how likely it is that portion of the gut that is involved to survive. Okay, and it will also determine the prognosis. So all the colics that all the surgical colics that Claudia has mentioned previously, they all belong to one of these three categories. But just to try to explain you a little bit what these mean. So we have the simple obstructions, which in fact are when some content within the intestine accumulates and forms an impaction inside the lumen, so inside the channel of the gut, and it starts to accumulate there, and it starts to distend the gut, sometimes to the extent that the blood vessels itself, because obviously the gut only has a certain amount of capacity and elasticity to stretch. Once that capacity has been overcome, sometimes the blood supply to a portion of that intestine may be compromised, and it can lead to infarction, so to a cut or to blockage in the blood supply to a part of that intestine. And we can see, as Manon is pointing there with the pointer, a portion that has been necrotized, so has died due to the fact that it's had poor perfusion for too long. To these groups belong the impactions, the parasites plugs or the parasite accumulations that we will see after as well, and also the enterolites, which are in fact accumulations of mineral inside the guts. And then we have the strangulating obstructions, and these are not only when not only the lumen, so the passage of the intestine, is blocked, but also the blood supply, so the blood flow to the intestine is cut. And this is normally because there's or a torsion or a volvulus or an entrapment, or a herniation, for example, that will lead to not only the passage of the content in the intestine to be cut, but also the blood supply. And these are really important to act quite fast, because the intestine degenerates quite fast when there is no oxygen and nutrients going to that portion of the intestine. And it's really important to act fast and try to resolve the problem. Sometimes, due to these strangulating obstructions, we have to really cut portions of the intestine out because they have already died, and if we don't do that, the horse will eventually die. So these are extremely important emergencies. And then we have the last group, which is a non-strangulating infarction, and that one is much less common. We rarely see them in the UK because most horses are quite well wormed and have good worming programs. And those are associated to a compromise in the vasculature only. So the passage within the intestine is good, but the blood flow to a portion of the intestine is compromised because there's inflammation in a portion of that blood supply. And these are normally caused by a parasite called the Strongylus vulgaris, which is one of the most common parasites of the horses. But they really request really high burdens for it to be a problem. Okay, we can pass. Okay, once the decision has been made to go to surgery, we have certain steps we have to go through. So normally these horses are quite debilitated, so they're very often dehydrated, and their acid base and electrolytes are very unbalanced, and it's important to check these and to make sure that the horse is in good shape enough. Obviously, they will never be as good as a healthy horse, so it's not an elective procedure, so it's an emergent procedure. So we try to stabilize them as well as we can and go for surgery. Obviously, we give all the pre-medications, meaning the analgesia and anti-inflammatories that most of the times we have already given by this stage, antibiotics and the sedatives to prepare them for the anesthesia. At this stage, we also place a catheter, so a cannula inside a vein. Sometimes, if needed, we even place two if we need to do really intensive hydration, and we place a tube in the stomach again. If that is not already there, because we want the horse to have the stomach decompressed throughout the whole procedure, including the knockdown, so the induction, because at this stage it's really important that the stomach is not under pressure. Before going to anesthesia, we also do the mouth rinsing, which is cleaning the mouth just to make sure that we don't drag any dirt that is inside the mouth into the trachea that could lead to problems after the surgery. We can pass, please, Manon. So the induction is done. So the induction is the putting asleep the horse so anesthetizing the horse, and we do that in a padded recovery. So to try to minimize the trauma and also to make it as smooth as possible, we do it with ropes. So we do a rope-assisted induction. And then the horse is placed, as we can see in the movie, in the table, coming from the induction room, is hoisted and is placed on the table with the abdomen facing up and the back onto the table. At this stage, we also place the tracheal tube, which is the tube that we place from the mouth to the trachea. It has a balloon, and we can inflate that balloon, and that will coapt perfectly to the trachea, and it will allow us to ventilate the horse throughout the whole procedure. This is really important because a lot of these horses have a lot of intra-abdominal pressure, so increased intra-abdominal pressure that will place a lot of pressure into the thorax, and that can really compromise their ventilation. So if we can do it mechanically, so a forced ventilation, that really helps us not only to deliver the oxygen, but also to deliver the anesthetic, which will be done by the air mixture. So the anesthesia is maintained through volatile anesthetics, meaning that they are mixtured. So we mixture the anesthetics with the air that we ventilate the horse with through a machine called the vaporizer. And then we have a ventilator, like I already spoke, that has a big balloon that will allow us to mechanically ventilate these horses. And then throughout the anesthesia, it's really important also to keep a close eye on how they're doing. So we have a lot of machines that allow us to monitor our patients very carefully and very closely throughout the whole anesthesia. This is really important. And we do that by measuring blood pressure, by checking the heart rate, by checking the rhythm, electric activity of the heart, the depth of anesthesia. And we do periodically blood gases, meaning that we take a sample of blood from the horse, put it in the machine, and we check how well oxygenated, what's the pH, and how all the parameters are to make sure that the horse is really stable throughout the procedure. Sorry. We also do several CRIs, meaning continuous rate infusions of different things. So mainly pain medication, also a medication that allows to control the depth of anesthesia and also to control the blood pressure. So there's really several steps that need to be taken in order for the whole. So it's really a teamwork, as you can see. So then the nurses and the assistants will help with preparing the skin. So we start by clipping, scrubbing, and placing a urinary catheter. This will allow us really to establish a sterile environment before we open the abdomen of the horse and try to avoid at all costs any infection. And we finish by placing the sterile draping, and then the surgeon, who is also sterile, will start the procedure, normally by cutting on the ventral midline. So where the mouse is now pointing on that little picture. There's other possible approaches, but this is by far the best and the most commonly used. The other ones are really alternative approaches, sometimes if needed, so the perimedian, the inguinal, and sometimes we do some procedures laparoscopically, but these are all quite rare. So 99% of the times we use the ventral midline. Okay, so then once the abdomen is open, the first thing to do is to explore the GI tract. So we try to understand what is going on there. Okay, so we cannot visualize 100% of the tract. So a portion of it is too attached to the internal walls, but we can palpate it normally, and we can visualize. So we can sterilize and visualize and palpate most of it, around 75% of the intestine. So we go through it all and see what is the site of injury. So what happens? We try to fix what happens, and a lot of times that includes a viability assessment, meaning that we try to see. You can pass, Manon, please. So we try to see if the guts that were involved in that process are viable or not. Meaning, are they healthy enough? Will they survive the surgery after, or should we do something about it by removing them? So we can see here on the left a colon where we can obviously see it's a bit darkish in color. Obviously, that's not the healthy appearance, and we can also see that there's a really reddish area in the middle where the blood supplies the colon in that area. So there has obviously been a compromise there where the blood has been cut into a portion of that colon. And then we have on the right, we can see a really pinkish so pale pinkish red, pale pinkish gut on the left. That is small intestine, and on the right we can see a really purple, dark, even some black-looking small intestine, and that is definitely not viable. So that will have to be removed. Otherwise, the horse has no chance. So, and here the next thing to do could be an enterotomy. So if we have to open to unblock a portion of the intestine, and in this case, it's impaction due to Parascaris equorum, which is a parasite that we see more frequently in foals until 6 months of age. It's rare to see this in older horses, but they can actually accumulate and form like a plug in the small intestine that needs to be corrected surgically. So this is also quite it's a common cause of colic in foals, especially the ones that have a bad worming program in place. We can pass, and then we have a colon enterotomy. So once we have an impaction in the colon that is not resolving and we need to go for surgery, what we do is opening the colon, and we put the colon on a tray that is already covered with a sterile drape as well, and the tray is descending, allowing us to, when we open the colon, that the content does not come back into the abdomen and doesn't have contact with with the other parts of the intestine that would lead to an infection of the peritonitis, so an infection of the abdominal cavity, and that is life-threatening. So we try to keep it as clean as possible, and by opening the tip and placing hose pipe into the colon and trying to flush this impaction out. So this is, and then what we have to do is clean that tip of the colon and suture it back together. Okay, and then here we have an enterectomy. So when an enterectomy means that we cut a portion of the intestine out because we think it's not viable, and we do that by cutting where, as you can see there in the left, a really reddish, very bad-looking portion of intestine. And if you compare it to the loop near the hand of the surgeon, it's much more light pink and much more healthy. So what we do is we cut those extremes and we try to suture the tips together, as you can see there in the right, the final appearance. Okay. So sometimes, and unfortunately, you can even go back, Manon, sorry. So sometimes at this stage we have to make some really difficult decisions. So if we think that the horse has a really bad prognosis because what we found is really dramatic, we call the owner, and we sometimes have to take the sad decision of not carrying on with the surgery. But most of the times that is not the case, and we go and recover the horses. But this would be the time that we would make that call. So once we have recovered, so if the horses, all the intestines are put back in the abdomen, there's a final overlook of how things are standing, if everything is in the right place, and then the horse abdomen is sutured, and he's placed on the recovery box. You can pass, Manon, please. And in the recovery box, the recovery is done with rope assistance, again, to make it as smooth as possible. Normally, these have been quite long anesthesias, so the horses take a bit longer to recover. They can be a bit ataxic, and they can take a little bit more time than usual to come back from these anesthesias. Also because they were in a compromised state when the anesthesia started in the first place. So we really want to give them the smoothest recovery possible. So we do that by assisting them with a rope, normally attached to a halter and to the tail. There are sometimes some post-operative complications. We think it's important that you are aware of that, including enotoxemia. So if portions of the gut that have been compromised can lead to a toxic state of the horse, these things normally we can correct medically after. Then we have post-operative reflux. So this is also something that we see in some horses because especially the small intestine have something we call ileus. So their movement, their motility is not back to normal because they went through a major event and they need a bit of time to recover. And for that, we have to place a tube in the stomach and take the reflux frequently, because as we explained, the stomach, if the stomach accumulates too much fluid, it can burst. So we have to keep doing this. So it's quite an intensive care. Rarely, but 10 to 12% of horses can develop adhesions, more frequently in the small intestine, as you can see there in this picture in the left. But this is quite a rare thing. And these, if it does happen, it could lead that there's a recurrence of a colic. And then sometimes we have abdominal wound infections. Most of these complications, we can deal with them medically at the clinic. But anyway, this is still, we still feel that this is a really important, probably one of the most important procedures we can do, because it's really life-saving if done at the correct timings. And around 60% of horses do survive these procedures. and a lot of them go back to the same, at least the same level of performance. And if they do survive until this stage, normally they have a long-term life quality. So we do think it's really worthwhile considering going for surgery. So really, just to kind of summarize this all up, once you think the horse has a colic, it's really important to call us, and we can discuss. We can go through it. It doesn't mean that we have to go there immediately, but we can definitely put your head at rest if we think that we are not needed. But we'll definitely try to guide you into what would be the best option for you and for your horse. It will also we also try to reduce the risk of colics with the different simple management measures that we have proposed, and it normally has a good prognosis if it has an immediate veterinary attention. So keep in touch if you have any doubt. Okay. We go for some questions.
Fantastic, thank you very much. Very interesting. We have a question here asking, how long does it take to stitch up the guts?
The guts?
Sorry, stitch the guts together. How long would it take to stitch the guts together?
It really depends on what location. So if it's a large intestine, it's obviously takes much longer. It really depends on how long the incision is, so how long the cut we had to make is, but it's definitely not the most time-consuming job of the whole procedure. So it's really important to keep it really clean, and that is sometimes a struggle, because obviously we're speaking about a very slippery kind of structure, and it's really, that has inside obviously fecal material or content which cannot have contact with the rest of the abdomen, or otherwise it could lead to a really bad infection. So we have to make sure that this is done as sterilely as possible. So that is really the most challenging part of this.
Nuno, on the back of that,
all clean. Yeah.
On the back of that,
to add, just also it's really depends of I think I would say about the surgeon. It's quite surgeon dependent. How long it takes to stitch a gut. So if you have a really handy and really rapid surgeon, it can be quite fast, but also it can take a bit more time. So it depends a bit of the experience also of the surgeon. But yeah, at the end, yeah, it depends also on the size. Gut, yeah.
And on the back of that, Nuno, how long would you expect an average colic surgery to take from start to finish?
I would say probably the average would be 3 hours, more or less, 2 to 4 hours, depending on how severe it is and what we have to do. So if it's really a recent strangulation, for example, that we can go in and no portion of the intestine has to be removed, these can be faster, but a lot of times we need to do some kind of procedure, including the enterotomy, so the opening of the gut, or the colon tray, so the colon flushing. All these procedures take a bit longer, obviously. So it really depends on what's going on, but I would say it could go from 2 hours to 4 hours, depending on what's the case, really.
And yeah, also induction takes quite a lot of time. The preparation before, it takes quite a lot of time, and the recovery also. So it's not like the whole procedure takes some time, but also the before and the after of the anesthesia is quite long also.
I think it's important also to tell people that we will keep in touch with you throughout the procedure, and also at the end of the anesthesia. So the procedure in fact ends when the horse is up, so when it recovers from the anesthesia. And at that point we will always give you a call and keep you informed how things went.
There's a question here. Presumably there is only a certain amount of intestines that you can take out of a horse. Carolina asks, how much is too much?
I don't have a specific answer to that, or I don't have a concrete answer to that question. I would say It's really based on the experience of the surgeon, sometimes the personal experience, but there is obviously we need an important part of the intestine viable for the horse to have a good prognosis, obviously. So if the injury takes too much of a so if the extent of the loop involved in the injury is too long, that will normally have a poorer prognosis, obviously. So the bigger the extent of the injured place, the worse the prognosis.
Claudia, did you want to add anything to that?
Yeah, so I was going to say, typically, if you take too much, you get something called short gut syndrome, and that can cause a lot of problems going onwards in terms of being able to absorb the nutrients from their food. So typically, we will just take, I think, around, it's no hard and fast rule, but around about a third of the gut is the maximum we'd like to take. So if we kind of have 25 to 30 meters of gut, we can be taking kind of up to 15 meters of gut away, but that is quite a lot, and we try not to do any more than that. I think otherwise the prognosis, you can, but your long-term prognosis probably would be slightly worse.
Thank you.
These are things we normally discuss sometimes intersurgically with the owner. So if the extent of the injury is really big, so it's really large, and we do decide this together with the owner, saying the prognosis is guarded or is poor. Do you want to give it a try anyway? We can try to do everything we can. So that's why it's not a static thing. So it's really variable, I would say.
Cool. Thank you. We're getting quite a lot of questions on here asking how much a colic surgery costs. Perhaps I can put some light on that. So these are ballpark figures. So you know, it really does depend on the situation. But is there such thing as a standard colic or a normal colic surgery? We're saying between £5,000 and £6,000 to allow for sort of an ordinary colic surgery, if there's such thing. If it's a more complicated colic surgery with a lot of intensive aftercare, then we're looking at more like £6,000 to £10,000. And I wonder, Claudia, could you just talk to us a little bit about the aftercare and what is involved in intensive care?
Yeah, sure. Yeah, there's been a couple of questions about this actually as well, in terms of the recovery. So in the initial period, it's quite intensive care for your horse, and they typically will be checked every half an hour to an hour with a clinical exam, and so that will be done throughout the night or throughout the day, depending on when the colic surgery occurred. We're looking at their signs of pain, their hydration, etc. We typically will have to have a stomach tube in place, and we might need to reflux them every couple of hours to make sure that their stomach keeps decompressing. Some horses will never reflux after surgery, some do. They may reflux for 2 days, they may reflux for 7 days. So it kind of depends on how your horse is responding to the colic surgery and how quickly we can get those guts moving. And that's all very dependent on the type of surgery that's undertaken. Typically, horses will be in the clinic regardless for 5 days because they need pain relief, they may need antibiotics, etc. If it's been a very standard easy surgery, they may be going home after kind of 5 to 7 days. If they are requiring very intensive care, they need to remain on fluids, they are still refluxing, it may take quite a bit longer.
Thank you, that's brilliant. And I guess just going back to the cost factor, it really drums home Manon's point earlier about knowing whether your horse is insured. And we do have horses that come into the clinic quite often whereby the client will think that the horse is insured for a certain surgery, and it's only once the surgery has been done or just before the surgery that we find out that actually the horse isn't insured, and that the owner perhaps has missed something in the small print when their insurance has been renewed, and there's been an exclusion put on. So it is so vital to know whether your horse is insured so that you can make those decisions, because it is a lot of money. We did some research earlier, actually. Interestingly, we looked at the prices of colic surgeries 10 to 15 years ago, and it actually hasn't increased a huge amount. So 10 years ago, the average colic surgery was about 5,000. Well, we're saying 5,000 to 6,000. So I thought that was quite surprising that it hasn't increased at the rate everything else has increased. In terms of, you know, the cost of drugs and everything else involved.
I would also say it's also a good idea to know what your limit is on your insurance policy, because typically with colic surgery, you know, most insurance policies will insure you to £5,000. So you are probably guaranteeing that you're committing a portion of your own money there as well. So it's always important to know what your extent is on your insurance policy.
Nuno, can I come to you?
Sure thing.
Question here. What are the signs of toxic shock? Toxic shock. You mentioned it in your part of the presentation.
So normally horses that are in a shock, they are the heart rate is really increased. So we have really high heart rates. They're normally sweating very profusely. The mucosas can look or quite pale or quite congestive. So they are altered as well. So these are typical signs of shock. Heart rate probably the most significant and most indicative one. So if we have heart rates in the order of 80s or 60s, we can consider the horse is in a shock.
Thank you. Manon, a question here. Can a horse suffer a displacement simply from rolling?
I would not say, I would say no. If your horses, they roll all the time in the field normally, so they cannot have, I don't think they will have really a displacement because of that. Sometimes if the gut is really filled, maybe it can be displaced, but I would say, yeah, I would not be too worried if your horse is just rolling. I would not be worried about is he going to twist, because you're going to have a look to your horse every day, because yeah, he's just rolling all the time.
And another rolling question, Manon. This gentleman, Mike's horses roll and stretch regularly. How would he know what to look for, and what's the difference in a suspected colic?
I think it's really about how your horse look. Does he look normal or not? If he looks really stressed or anxious, or maybe a bit more agitated than usual. If he's just, you know, if he's rolling normally, and then when you go inside, it's just really bright, looking at you, eating well, passing droppings, I would not be too worried. If he starts to show, not passing droppings, or being a bit more or agitated or depressed, I would just consider the colic.
Thank you. Nuno, if a horse, my screen's just flipped. If a horse has an acute colic stage and is on the floor rolling around thrashing, how do you physically get them to the clinic?
So normally we try to, with heavy sedation. So normally the vet will have to go there and to give them a good amount of sedation. Surprisingly, they do cope with it quite well. And yeah, it sometimes is a problem. Definitely, I understand the question completely, but most of the times I would say we can control it with heavy sedation, enough to bring them into the clinic. But yeah, it sometimes is a problem. I agree.
Thank you. And we have a question here from Fiona.
I think the most important thing, or the key factor, is not let it go to that stage. Okay, if the horse is really showing signs, call us straight away. If it's not responding to painkillers, we will take them to the clinic straight away, and not wait for this to happen, because normally it doesn't happen all of a sudden. It takes a little bit of time until it goes to a very severe stage of colic.
And presumably in that situation, you know, clients can take the petitions out of their trailers and lorries and things like that. If the horse is potentially going to lie down, then it's, I imagine, probably best just to remove the petitions in that instance.
Yeah. And yeah, if you have your horse in the trailer and you're going to the clinic, if you hear the horse like going down or rolling, just go straight to the clinic. Don't stop or don't open the trailer. You're not going to do anything on the road, and it's not safe. So just, even if you hear your horse lying down or anything, just go straight to the clinic. Don't stop.
Really good points.
Do not go in there either.
Yeah.
Never travel with your horse in the trailer.
Claudia. Does the age of your horse affect their chances for a good outcome from surgery?
I think age regularly plays a part in people's decision-making process. Age, number one, can be a massive factor as to whether your horse is covered for colic with your insurance policy. Very regularly on veteran policies, they aren't. In terms of whether they have less likelihood of recovering, possibly not. Sometimes yes, it kind of depends on the type of the lesion. So older horses are more predisposed to getting these fatty lumps rattling around, and obviously if they've been left and there's a large amount of gut that's dead, that would not be a very good prognostic indicator. But in terms of, does an old horse, just being old, does it make them more likely to die from colic surgery? No, I don't believe it does. But there are many other factors that come with being an older horse that might prohibit you from taking it to surgery.
Yeah, the older I got on surgery was 32, I think, something like this, 32 years old, so quite old. So of course, for anesthesia, we are quite anesthesia, the heart can work a bit less, so we have maybe a bit more risk in anesthesia than a normal healthy horse because he's a bit old. But yeah, this one is fine and happy in the field now. So yeah, it's not because he's old that he has no chance of surgery.
Thank you. Claudia, I'm gonna stay with you. We have another ulcer related question. If a horse has a history of ulcers and is starved for several days with colic, what is the likelihood of the ulcers recurring?
Yeah, so there's a problem sometimes. So if a horse has predisposed to ulcers, number one, being hospitalized with colic surgery is a stressful period for your horse, which may predispose them to getting ulcers, and also they are not having any food in their gut. So if we know that the horse has a problem, sometimes we can treat them with ulcer medication systemically to try and stop that risk from occurring. So that's probably what I would recommend. Yeah, so try and stop them forming. Yeah, the colic is probably going to be the bigger risk than the ulcers, so we do need to treat that appropriately. I mean, there are medication that we can inject into their muscles, so they're not having to receive any oral medication for their ulcers to try and stop that occurring.
Thank you. Manon, I know you touched upon this earlier, but Alison is asking, if the horse looks like it's suffering from colic, do we allow them to lay down or keep them up and walking around until the vet arrives?
So yeah, so it depends a bit of what are the signs of your horse, if your horse is calm or if your horse is really violent. If your horse is calm and it's safe to walk him, it can be a good idea to walk him while you're waiting for the vet. But if you see your horse is lying down or rolling, even if you start to walk, you see your horse doesn't want to walk and wants to lie down, I would just leave it in the box or in the same school, not try to just not try to walk him, just because it might not be safe for you.
Thank you. Nuno, I have a question here. What causes a displacement?
Yeah, it's really difficult to know exactly what causes it. I think there is definitely an anatomical predisposition for that to happen. Like I think Claudia already explained, sometimes the ligament is a little bit too lash or too long, or for example, if we were speaking about a nephrosplenic displacement, but in general, I think it's really their specific anatomy in conjunction with some episode. It could be because there's a spasmodic colic, for example, that makes the intestine, the peristaltism, which is the movement of the intestine, increase quite a lot. And this could lead to displacement because there's a bit of an impaction, for example, and the horse did a certain movement, or we don't really know why the displacement happens. We know it's the anatomy of the horse, the fact that it has quite loosened portions of the intestine hanging, that can lead to displacements. But exactly what is the event that provokes it, I think we have no concrete answer to that.
Thank you, Nuno. So we have just hit an hour and a half of this talk. I'm very surprised, but we have kept 90 attendees watching, which is absolutely fantastic. So I think we probably quit while we're ahead. Does anybody have anything else from the panelists that they want to add before we close up this question and answer session?
No, I'd just say if there's any questions that we haven't answered, feel free to email us. Our emails are all on the website, and we can go through anything that we haven't been able to cover.
Yeah, I think we just didn't mention the time for being like recover after the surgery. Just quickly, normally we count 3 months of box rest, and then they can start again really slowly to go back to exercise, well, to paddock first and then exercise, etc. Just to let you know, it's more or less 3 months of box rest.
And when we talked earlier about the different costs involved with colic and the different amounts of intensive aftercare, am I right in thinking that sort of a good case scenario would be 1 or 2 days of intensive care afterwards, and in the sort of more complicated cases that this could be up to 10 days of intensive care? Is that right?
Yeah.
Seems like a reasonable time frame.
Yeah. Okay. Thank you. Okay, I think just a massive thank you to all three of you. It's been a really, really informative talk. I've certainly learned a lot this evening, and I'm sure our viewers have. We do hope to do some more of these live webinars. We've got one planned, hopefully in the next couple of weeks, in conjunction with Bailey's horse feeds, and we're going to talk quite a bit about the feeding in colic and the recovery from colic with the representative from Bailey. So keep an eye out. We'll do an email campaign and some Facebook campaigns to let you know when that will be. If you have any specific suggestions or feedback on this evening or for future webinars, please email me, jack@cliffequine.co.uk, and we would love to hear your feedback. Thank you very much. Have a lovely evening, and we will see you soon.
Thank you very much.
Thanks.
Everyone.
Bye-bye.
Bye.
Yeah.